Good morning, everyone. The time is 10 a.m. and it's time to start the webinar. I can see people joining. I guess we can just start as they join. So good morning once again, and welcome to the second edition of the Lassa Fever Clinical Management webinar series. I'm Abdulaziz Kuna, and I'm honored to serve as your moderator for today's session. On behalf of the Nigeria Center of Disease Control and Prevention and Georgetown Global Health Nigeria, I extend our gratitude to all participants for joining us this morning. To officially kick off our session, I would like to invite Dr. Bala Buratai to give the welcome remarks. Dr. Bala, go ahead, please.
Hello, can you hear me?
Yes, we can hear you, Dr.
Yeah. All right, thank you. Thank you for this opportunity. Good morning, everyone. I would like to, it's actually a great privilege to welcome you all to this very important webinar series. Like he has rightly mentioned, this is the second edition of the monthly webinar on Lassa Fever clinical management. The initiative is an initiative from the University of Georgetown University and its affiliates in collaboration with the Nigeria Center for Disease Control and Prevention. As you know, Lassa fever still remains a significant public health challenge in Nigeria and across the West African settings. We see a pockets of reoccurring outbreaks leading to high mobility and mortality. And this mortality from Lassa fever are mostly due to renal complication, specifically the acute kidney injury. So this very second webinar is going to be focusing on renal complications. How to address this renal complication of Lassa fever. So I would like to encourage all of us participating in this webinar to be focused and participate in this webinar, as today we are opportune to have some renal experts who are fellows of the Lassa Fever Clinical Management Fellowship. They will be sharing their experience on identifying, managing, and navigating post-treatment care of this very complication, the renal complication of Lassa fever. So at this point, I would like to encourage everyone to participate in this webinar, and let's try and utilize this opportunity to learn. So without further taking much of our time, on behalf of the DG of Nigeria Center for Disease Control and Prevention and the lead of the National Technical Working Group for Lassa fever, I wish us a very productive and insightful webinar. Thank you all, and over from me.
Okay, thank you, Dr. Bala, for the welcome remarks. So we're supposed to have Dr. Yetunde with us, the incident manager for Lassa fever, but unfortunately she's on transit. So I'd like to quickly give the objectives of this webinar. So our main objectives for developing this session, focusing on renal complications, is to describe the mechanism for kidney damage by the Lassa fever virus, And we also like to examine the clinical manifestations and diagnostic indicators of renal complications in Lassa fever patients. We also like to ensure that we understand the management modalities and supportive care to improve patient outcomes. So with these three objectives in mind, we plan to dive straight into the discussion. We'll have two parts of the presentation. The first will be a presentation on the pathophysiology and management of renal complications of Lassa fever, which will be taken by Dr. Tuko Moses, who is a consultant physician and nephrologist, and also a public health specialist with 19 years of clinical experience, including 7 years as a specialist. He's one of the pioneer Lassa fever case management fellows, and he holds certification in infection prevention and control from NCDC, WHO, and Africa CDC. At the Federal Teaching Hospital building in KBY, he coordinates the Infectious Disease Isolation and Treatment Center. He has several publications and has delivered numerous public lectures at universities, conferences, and workshops. So after his presentation, we'll have a case of Lassa fever with a renal complication that will be presented by Dr. Mojid Olaitarafiu, who is a chief consultant physician and a nephrologist at Irwa Specialist Teaching Hospital, Edo State. He's an honorary lecturer at Ambrose Ali University, Ekoma, and he has over 28 academic publications in national and international journals. He has contributed to the development of national guidelines on infection prevention and control for viral hemorrhagic fevers, led by NCDC. He has extensive experience in Lassa fever case management and has served as a facilitator for the Lassa fever clinical management fellowship. He was a team lead in several national outbreak responses, including the ministerial task team on COVID-19 and the 2024 Lassa fever outbreak response to 44 Army Reference Hospital, Kaduna. So we are privileged to have these experts to share their knowledge and experience with us today. And without further delay, I would like to invite Dr. Tuko Moses to begin his presentation on the pathophysiology and management of renal complications of Lassa fever. Dr. Tuko, over to you, please. Thank you.
All right, good morning to
Good
the
morning.
moderator and the participants. I'm pleased to have been invited to make a presentation on this very important topic that has actually become a very big burden for the Nigerian healthcare system, especially healthcare workers. And it's also a Nigerian born and bred disease. So to start the presentation, I will hope that you can see my screen.
Yes, we can see it.
Okay.
But it's
Is it on
not
slideshow now?
Not yet.
Oh, okay. I believe it's on slideshow.
I see it now.
All right,
Yes,
good. Thank you very much. Yeah. Thank you very much. So, like I said, thank you for the introduction and thank you for the opportunity. So in the next 20 minutes or thereabout, I will be taking us through the pathophysiology and management of renal complications of Lassa fever. So I will be using this particular outline. Within the period, we'll be looking at introduction very briefly, and I'll look at the virus itself, and we'll do a nosedive into kidney injury. I will look at pathomechanisms of AKI Lassa fever, which is a very important component of this presentation. How does it cause acute kidney injury? Then how should clinicians or case management physicians identify AKI? Then how should they go about managing? And if there is dialysis, what is it all about? And what are the other abnormalities that come with AKI? Then we'll definitely do a conclusion. So let's get to business. I've just decided to come up with some brief introduction, actually keeping it very short, because in the last webinar series, we dealt seriously on the Lassa Fever virus, historical perspectives, presentations, and all that. I remember by Dr. Joseph Okogwale. So just to connect from that last presentation to now, it's important to know that Lassa fever is a viral hemorrhagic fever, is one of them. And we all know it's caused by an envelope single-stranded bisegmented. Importantly, it's a Nigerian disease because it was discovered in Nigeria sometime in 1969. We remember the historical perspective of the two nurses and who first had the infection, how, and all the stories that followed as presented in the last presentation, and eventually in the early virus lab in US where it was first identified. It's endemic in the whole of West Africa, several countries, but predominantly Sierra Leone, Liberia, Guinea, and Nigeria. So, and it's a zoonotic infection, like we have said, and it's a disease of humans in West Africa as well. It's characterized by high fever. A good number of times this is what people look out for. We say high-grade fever. And however, it has a wide spectrum of clinical manifestations affecting almost every organ, systemic, widespread. But very importantly, it could cause bleeding, which is the hallmark that our healthcare workers wait for before they say this is possibly a suspected case of Lassa until that bleeding is seen. But for us today, we're looking at the acute kidney injury component, which is a major cause of mortality. So it's transmitted by mastomys, special rodents. And I've already said this, it occurs in outbreaks. A single case actually makes an outbreak. And in Nigeria and other countries, we have generally 2 peaks towards the dry season, just like we have towards the end of the year. And at about this time, February, March, April, as we see in the IRWA series that have been variously described and presented. Various factors have been ascribed to it, as in the heat, bush burning, and all that. But Lassa virus is primarily transmitted to humans through contact with infected feces or urine of these mastomys rats. But there's an important component of transmission, which today makes a very big cause of mortality and morbidity, which is commonly in healthcare settings, which is human-to-human transmission through direct contact or indirect with body fluids of infected individuals. A good number of healthcare workers have been lost through this human-to-human contact from unsuspecting cases of Lassa fever, either by pregnancy, unsuspecting with crypto manifestations, or sometimes even where the cases have looked like overt cases where ENT, sore throat, and they were missed. So symptoms range from mild to severe cases. In fact, up to 1/3 of the cases is said they will just pass without any symptom. They could be asymptomatic. And for those who have symptoms, a good number of them also present with mild symptoms, just joint pains, fever, malaise, anorexia, and perhaps nothing. But in somewhere about 1/3 of them, symptoms could be severe. And these early symptoms, when they occur, like we said, could be fever, weakness, headaches, and sore throats. So a good number of patients could just stop at this level and there will be no manifestation of severe presentations of Lassa fever. But where there is severity and it worsens, we could have more serious features such as hyperpyrexia now, where we see a good number of patients running high-grade fever that could extend up to 38 to 40 or even higher. We could have respiratory distress. And somewhere in the background, hearing loss has been reported. Spontaneous bleeding. This is where healthcare workers often miss the point and wait until we see spontaneous bleeding, either from the skin, particularly ecchymosis, or from the orifices, mouth, nose, and genital tract, gastrointestinal tract. And sometimes, like we said, like Dr. Joseph presented last week, could complicate pregnancy, either spontaneous bleeding, and mimic all those abruptio, and as the case may be, and sometimes is missed by the gynecologist. But kidney injury is a manifestation, and it could come with seizures, loss of consciousness, and ultimately in the pathway of mortality, we'll have multi-organ dysfunction. But kidney is one of the major organs, and kidney failure is the most common component of this multi-organ dysfunction that occurs and complicating Lassa fever, and commonly the cause of death in our cases. So now we're going to have a lot of nosedive and have emphasis on acute kidney injury. And AKI, we know, is a challenging problem for most developing countries, Nigeria particularly. And because of the burden of the disease and lack of resources to support patients with established AKI. Generally speaking, AKI is a disease that has a broad spectrum. So like I say, it's a spectrum that occurs from asymptomatic presentation to severe end organ dysfunction, where we have the uremic manifestations. And generally speaking, once there is acute kidney injury, there's a need to have support base from conservative to active intervention, which may involve renal replacement therapy. And we have shortage of resources in Africa and in Nigeria particularly, and it becomes difficult to support our patients. But we know that AKI is a frequent complication of Lassa fever. And prevalence rates have been reported mainly in the ERA series and in many other studies to be as high as 28.5% among patients who have been hospitalized with Lassa fever. Now, a good number of these reports are for those, if you look at the study design, for those who have manifested features of kidney failure. A few studies were done by nephrologists to pick AKI in the early part of the spectrum, and it's thought that the frequency or prevalence rate is much higher than the 28.5 reported. In fact, AKI is associated with, is one of the complications associated with patients with confirmed Lassa fever, and in over 60% of cases accounts for the case fatality of Lassa fever. Now, what is this AKI? Previously, it used to be called renal failure, but like I said, in the nephrology spectrum, we see it as a spectrum of disease that occurs from just mild injury up until kidney fails. So it's no longer failure. The terminology has moved to acute kidney injury so that we can pick disease component early. Now, up to 18% of hospital admissions are thought to have AKI. In many cities, including the ones that have been done in Nigeria, it's thought that the prevalence could be higher. And the commonest cause of it remains sepsis. I will look at how Lassa fever on its own accounts for this. So mortality generally as much as 25 to 30%. Now, it's very important to note that of this percentage, as much as 20 to 30% of AKI are preventable. And we're looking at Lassa as a case study for this. And prevention of it could save up to as much as 12,000 lives each year globally. Now, minor degrees of kidney dysfunctions are associated with prolonged hospital length of stay. I believe when we have the second part of the presentation, looking at a case study, we may be able to see how patients who have kidney injury tend to have worse outcome, including prolonged duration of staying in the hospital. So how do we define this acute kidney injury? Very simply put, there are very many, there are three major criteria definition system. This for kidney disease improving global outcome, and it has remained the world standard definition. And it's easy for clinicians and physicians, whether in the rural areas or in the big cities, to be able to unify to identify acute kidney injury. Now, once there is a rise in serum creatinine, which a good number of times most facilities are able to assay, of greater than 26.5 micromole per liter within a 48-hour period, it qualifies for acute kidney injury. Now, it's also important to note that if you have the benefit of having baseline serum creatinine of our patients, which is actually the practice in most advanced climes, and most of the time not the practice in our own setting, except we have reason to suspect we don't have baseline. But once you have a greater than 1.5-fold rise in serum creatinine from the baseline within a 7-day period, it also qualifies for acute kidney injury at any point in time. So 7 days is a spectrum of time. So, but importantly now, even for setups where we cannot have serum creatinine, the one everybody can be able to use to define kidney injury is urine volume. Everywhere, whether in a primary health care center, but particularly in our small hospitals where cases of Lassa may occur, it's important to monitor for urine volume. So once there's a decline urine output, less than 0.5 ml per kg per hour, for at least 6 hours, then it qualifies for there's some form of acute kidney injury. But generally speaking, once there's an abrupt decline in kidney function, so we'll be able to estimate for GFR or calculate within hours to days. Now, when we look at the acute kidney injury network definition, we are having anything that causes structural, that means by the structure of the kidney itself, which could be radiological, it could be physical, the manifestation, or there's a functional abnormality, meaning that we see symptoms that suggest that there's kidney impairment. We could be either early morning facial puffiness, or there are markers of kidney damage, which include abnormalities in urine. The common ones we should note here are hematuria and or proteinuria. So, and all these abnormalities which are present for less than 3 months also qualify for acute kidney injury. So let's be specific now. We now know that AKI has 3 major mechanisms of occurrence. It could be before the kidneys, from the very, very basic medical knowledge. It could be at the level of the kidneys, and it could be after urine has been formed at the kidneys, that's post. So, you know, having this background knowledge for acute kidney injury, we will now see how we'll use it specifically in the setting of Lassa fever, how acute kidney injury occurs. So when there's compromised renal perfusion, you know, affecting supply of either blood, nutrients, or fluid to the kidneys, that's perirenal acute kidney injury. Intrinsic, where there is parenchymal injury, either at the level of glomerulus, or the level of the interstitium, or at the tubules where urine is filtered and reabsorbed. Or we have ischemic changes that occur to any of these structures. This is intrinsic kidney acute kidney injury. Then postrenal, where urine has been formed and urine is supposed to be excreted via the outlet tract through ureters, urethra, all the way to the prepuce, whether male or female. Once we have any form of obstruction at that level or impairment in excretion, it qualifies for post-renal acute kidney injury. Sorry, Gunnar, confirm you can still hear me, please, because I'm looking at my slide. I just want to be sure.
Yes, we can hear you, and just to note that you have just above 10 minutes left.
All right, thank you very much. So the pathomechanisms, I'm going to spend some more time here. There are many ways Lassa fever, Lassa virus causes acute kidney injury. It could be direct infiltration, which is a common pathway. The virus itself is thought to directly infiltrate the tubular cells and has a cytopathic effect, which leads to acute tubular necrosis, giving a form of intrinsic kidney dysfunction. Now, sometimes, other times it's immune mediated, where there's release of pro-inflammatory cytokines, chemokines, microvascular permeability, leading to interstitial nephritis itself. Now, the common one people may know much is coagulopathy. It causes some form of bleeding and injury to the microvascular vessels, causing thrombosis. There's leak through the vessels, endothelium of the vessels, and there's kidney ischemia. This is yet another way it does. Then importantly, there's hypovolemia and shock. A good number of these are patients, when they have acute, you see Lassa fever patients, they have high-grade fever. They are losing fluids. They are unable to take fluids. And they are definitely, you know, in the setting of hypovolemia, there's decreased perfusion of the kidney. And sometimes they even worsen by having hemorrhage. Now, this also worsens kidney ischemia and the perfusion is impaired. They will have kidney dysfunction. Then there are other presentations that occur, such as metabolic and electrolyte imbalances, which complicates infection, acute Lassa fever virus infection. Now, this triggers electrolyte dysmetabolism, and very importantly, we have hypokalemia and hyperkalemia, and hyponatremia. Now, it's important to also note that the secondary infections, which occurs, like you may see in the cases that may be presented, sometimes we have coexisting infection from other organisms, especially bacterial infection, which exacerbates kidney dysfunction, sepsis being the commonest cause. Now, it could occur from dysfunction following other adjunct therapy, NSAIDs, particularly. A good number of our patients would have taken NSAIDs. Then don't forget the mainstay of treatment is ribavirin, has nephrotoxic components. Sometimes we have patients who have taken aminoglycosides and there is. Then we have toxic nephritis, which we have seen in some of our patients taking herbal medications all before presentation. Now, how should clinicians identify AKI? First, like we say, is a spectrum. It could be asymptomatic. So if you do not suspect, you will not be able to pick that there is acute kidney injury. So suspect promptly for all cases of Lassa fever. Then screening is very important. How do we screen? Assess fluid balance. All patients with Lassa fever should be assessed for fluid balance and hydration status. They could have evidence of dehydration, and that is one of the early suspicions you should have of acute kidney injury, even before samples have been taken and sent for serum creatinine assay. All patients at presentations or at complaints, symptoms suggestive of Lassa fever must have serum creatinine assay done. And serum creatinine assay on its own is not enough. It's important to calculate glomerular filtration rate by estimates. Of course, these days we have a lot of apps. The CocoGot app that is in people's mobiles you can use. Then for patients who are now hospitalized, it's important to not just do the baseline, but is to also do a daily assay. But in advanced climates, it's recommended to do 12 hours assay. If you remember in the diagnostic criteria, we said when there is increase in serum creatinine value from baseline, which could be hours to 7 days, but importantly in 48 hours period. So patients with critical illness, you should measure EGFR and continue to compare according to the baseline on a daily basis. Then measure urine output in the first 6 hours, in the 12 hours, and daily urine output, because these are the markers that will suggest acute kidney injury in the first instance. Of course, not forgetting urinalysis, because urinalysis, there are other factors that could affect it, but the presence of proteinuria and hematuria at presentation or at the first contact are strong indicators and suggestive of acute kidney injury from Lassa fever. So how do we investigate? So we detect and investigate. I've mentioned those baseline things we should do, and we should remember what I've said: a rise in serum creatinine of 26 micromole per liter within 48 hours, or 50% rise in the baseline, or urine output less than 0.5 ml per kg per hour for the first 6 hours, consecutive hours, is very important. So, or we have, like we said, looking at another criteria, the same thing. If we have 1.5 to 2-fold to 3-fold rise, all of it qualifies. So it's just for the purpose of staging. But beyond the staging, what is important and the take home is that a rise in serum creatinine of 26 micromole per liter or 1.5-fold increase is already in the early stage 1 of acute kidney injury. All others will only be worse stages of AKI. Then important to note urine output when we have less than 0.5 ml per kg for 6 hours, then for 12 hours, and for 24 hours. So what are the main goals of principles of management? It is to assess fluid balance, like we said, from assessment. Then what you do depends on what is the fluid volume status of the patients. Patients are categorized generally into 3 when there is acute kidney injury following Lassa fever infection. They could be euvolemic, that's normal volume status. They could be hypovolemic, that's where they have features of dehydration. They could be hypovolemic, where they have features of fluid retention, as evidenced by a simple edema, worsening all the way to pulmonary edema. Then it is important to note that for those who are dehydrated, losing fluid, pre-renal AKI, fluid therapy is the mainstay. And not dialysis. Replace fluids, and if it's blood loss, replace the blood. Fresh whole blood is the mainstay of replacement for those who are having bleeding. And replace and correct hydration. That may suffice on its own while patient is having other supportive therapy to recover from acute kidney injury, including giving of antipyretics, because hyperpyrexia worsens volume loss, fluid loss, and of course, it worsens kidney injury. So it's very important to know this major principle: volume status, fluid therapy for hypovolemic status, then furosemide, that's IV furosemide, loop diuretic is the mainstay for those who are hypervolemic and they are retaining fluid. So it's not all patients qualify, as often erroneously done in most cases, we say challenge kidney, challenge kidney. So in severe AKI, kidney replacement therapy may include hemodialysis. So we now move to hemodialysis. What is it? It's, of course, an intervention that is given for patients who have become, who have developed kidney failure now. And that kidney failure often evidenced by presence of uremic symptoms, which are either the bleeding may be from Lassa itself or be from uremia, then pulmonary edema, and electrolyte imbalance like hyperkalemia, and the rest of them, including coma. It's a very important life-saving intervention in Lassa fever, in severe Lassa fever. And dialysis should be supervised and closely with strict IPC, because it's one of those ways that, it's a blood-borne procedure and it could lead to spread. So in dialysis, heparin is given as part of the treatment. Sorry, as part of the measures to prevent extracorporeal clotting of blood. So sometimes when dialysis is, heparin is given, it could, in patients who have already developed complications of bleeding, it may worsen the bleeding. And it may require giving fresh whole blood transfusion. But nephrologists should know better when to avoid and do heparin-free dialysis for patients who have AKI and evidence of bleeding. Peritoneal dialysis is not an option recommended because it's a very highly infectious disease. Now, survivors for AKI should be assessed for recovery of kidney function, as we may see in the case that will be presented, and possibility of progression to chronic kidney disease, which exists. So it's important to know that in the management, we have medical management, like I have described earlier, and will proceed all the way to dialysis when medical management may not suffice. Now, it's important to restrict dietary potassium at the onset, because hyperkalemia is a commonest cause, even in AKI, of arrhythmias and death. So watch out for hyperkalemia as from basic medical practice, and for severe hyperkalemia, intervention should be made. And those intervention includes baseline giving of calcium gluconate to protect the heart, dextrose insulin infusion, and loop diuretics for those who are volume overloaded, not for those who have hypovolemia. Then for patients with oliguria, we could also give potassium exchange resins that would now suffice for that group. Now, for severe metabolic acidosis, it's important to note that we should use sodium bicarbonate, which is not necessarily, except in severe when nephrologists are quite involved. But for general practice, let's watch out for things like hypernatremia, increased water intake via enteral routes to take care of that situation. There could be hyponatremia, there could be hypercalcemia, there could be hyperphosphatemia. And all these are a spectrum of electrolyte abnormalities that could occur. And once we know that they could occur, it's very important that we watch out for them and restrict phosphate intakes or bisphosphonate and give diuretics where our patients are volume overloaded. They could actually help and make the difference. Loop diuretics are a mainstay. Now, what is the take home of what I've been discussing in all this period? First, AKI in Lassa fever is very common. It's life-threatening, and it's a leading cause of death. Since Lassa fever is endemic with us in Nigeria and in Africa, it's not enough to know Lassa fever and be able to manage. It's important to know what causes mortality most. as acute kidney injury, and we have dedicated today to look at it. So clinicians must take every necessary step to promptly identify features of AKI from the symptoms itself, but the most important one is urine output. Always ask what is the urine output from the onset of symptoms, whether the patients are asymptomatic. Is there any form of objective decline? And when patients are inpatient, we should not run away and assume because they have high infectious disease, no, nobody is paying attention. We have to pay attention to the urine output. In 6 hours, what is the urine output like? In 12 hours, what is the urine output like? And of course, in 24 hours. Because if we do this, then we'll now be able to have timely intervention. And that timely intervention includes replacing what is missing. Fluid therapy for those who are volume depleted, and we may also give Lasix for those who are volume overloaded. But this, including blood transfusion or fresh blood for those who have bleeding. All these measures are very important and life-saving in the first instance before dialysis is offered as a life-saving procedure on its own. Now, that is for areas where dialysis is offered. It should be under strict IPC, and there's a need to have trained dialysis team and supportive dialysis facility at all treatment centers, because dialysis alone, as we may see in the case presentation, may be the game changer for those who have developed acute kidney injury and severity has progressed. Now, in the overall, AKI in setting of Lassa fever requires special attention, and we are giving it special attention today due to its enormous contribution to mortality despite intervention and treatment of ribavirin, as we may find in the case presentation. So I want to thank you all for listening to me, and I hope I will have many questions that will give us more room to interact and explain more. Thank you very much. These are my references.
Thank you very much, Dr. Moses. This is really a very insightful presentation. So if you have questions, please put them in the chat. And for those wanting to ask directly, you may have to wait till we take the second presentation. So I would like to call on Dr. Rafiu to kindly proceed with his presentation. Thank you.
Hello, good morning, everyone. Am I audible?
Yes, you are audible.
Okay. My screen is not appearing. Okay, let me probably try to start again. I'm still seeing grazes for my hand.
Okay, maybe you can try sharing again. I think.
Okay, I've shared now. I want to
Yeah,
put
so we
the
can see your
slide
screen from our end.
Okay. Thank you very much. I want to appreciate the Nigeria Center for Disease Control and the Georgetown Global Health for giving me the initiative, the privilege to discuss on this very important topic. I must thank Dr. Moses Chuko for doing justice to the renal complication and making my work quite easy. He has set the foundation, so that will make us to understand the evolution of symptoms. Okay, so now permit me to do some introduction for Lassa fever, because it cannot be emphasized. We need to constantly remind ourselves, and this will put the case illustration into perspective. Once again, Lassa fever is a viral hemorrhagic fever caused by a single-stranded envelope RNA virus called Lassa fever virus. It is the most important member of the arenavirida family and is mostly transmitted through contact with blood, urine, excreta of infected rats, or infected human body fluid. This is very important. The reservoir host of the virus is the multi-mammate rodent called Mastomys natalensis. Incubation period range between 3 to 21 days. It is endemic in West Africa region, with regular outbreak reported in Nigeria, Sierra Leone, Guinea, Liberia, and others. In fact, we currently have an epidemic going on. The mortality is between 10 to 20%. But mortality can either be as high as 65% in hospital outbreaks. In a 6-year study that we did in Ira Hospital that we published in Lancet Infectious Disease, we find the overall case fatality rate to be 24%. But we should note that in endemic area, we see sporadic cases of Lassa fever all year round. Beyond that, Lassa fever has also been known to be exported to foreign regions like USA, Canada, Europe, and Asia. The feature of Lassa fever can be asymptomatic, that is, the patient has no symptoms. It could be subclinical. We could have mild clinical disease, and we could have severe multisystemic manifestation, with acute kidney injury being a relatively frequent manifestation. So what is this acute kidney injury? I want to put it, to define it in a way that everybody will comprehend before I go to the technical definition. Acute kidney injury is a syndrome characterized by abrupt decline in glomerular filtration rate, occurring over hours to a few weeks, resulting in one or more of the following: accumulation of nitrogenous waste, disturbance of extracellular fluid and electrolyte balance, as we are going to see in the case illustration, disturbance of acid-base homeostasis. Every cell in the body requires a controlled acid-base milieu to function. That's what I said, that the function in every organ in the body depends on the kidney. But with kidney failure, this homeostasis is disrupted, and that will cause problems, can result in mortality. So acute kidney injury is seen up to 28% of patients treated for Lassa fever in our facility, Ira Hospital. Now, to a more technical definition of acute kidney injury, so that when somebody is making a diagnosis of acute kidney injury in, let's say, Jebu, and somebody is making it in Canada, somebody is making it in UK, it is the same, and this for research purpose. Kidney disease improving global outcome define acute kidney injury as increase in serum creatinine by at least 0.3 mg per dl occurring within 48 hours, or an increase in serum creatinine to at least 1.5 times baseline value, which is known or presumed to have occurred within the prior 7 days, or a urine output that is less than 0.5 ml per kilogram body weight per hour for 6 hours. Acute kidney injury is an important complication of Lassa fever that is strongly associated with poor outcomes. Okay, an outcome measure does not necessarily imply mortality. It can be prolonged hospital admission. It can be new onset complication, organ failure. Acute kidney injury can lead to this. Patients with acute kidney Lassa fever have a higher case fatality rate of about 60% compared to patients with Lassa that don't have acute kidney injury, and this is very significant. Last year with acute kidney injury had a lower blood urea nitrogen to creatinine ratio, suggesting increasing renal damage as the predominant causes. When Dr. Moses was talking, she talked about prerenal AKI, intrarenal AKI, and postrenal AKI. There are measures that we nephrology use to determine is this AKI, acute kidney injury, is it prerenal or intrarenal. So one of the measures is the blood urea nitrogen to creatinine ratio. And based on the study that we've done at Lassa Fever Hospital, we discovered that the BUN to creatinine ratio is low in most of our patients, which is suggestive of intrinsic damage to the kidney as the predominant cause of AKI in them. Elevated serum creatinine. Serum creatinine is a surrogate marker of transgenic waste. When it is elevated in the body, it will be indicating that the kidney is not functioning very well. Elevated serum potassium, aspartate aminotransferase, which is a reflection of liver damage, we have found to all be independent predictor of death in patients with Lassa fever. And we also observed that normalization of serum creatinine in patients with Lassa fever was associated with recovery. This implied that successful treatment of acute kidney injury significantly reduced mortality in this patient team. So what is the outlook in this year outbreak for us at Lassa Hospital? By the end of January this year, we have had 75 cases, 52 adults, 23 pediatric patients. Out of the adults, we have 28 males and 25 females. Means that there is really not much difference in the male to female ratio. For the pediatric, we have 12 males, 11 females. Out of these 5 cases, we had 10 mortality, that is death. 7 of these were adults, 3 were pediatric patients. And if you look at this mortality, you see that it tends to be higher in male than female. 6 male, 1 female. Despite the fact that the male to female ratio of those patients with Lassa fever was not really significantly different. Out of these 10 deaths, 6 of these patients had acute kidney injury, to tell you how significant it is and how related it can be to mortality. 3 of these were adults, 3 were pediatric patients. Now to the case illustration proper, I try to set a foundation to put this case illustration in context. We had a 27-year-old theology student who was also a polytechnician, a male, was a Christian from Uromi in Edo State. He presented with fever, headache, and vomiting of 2 weeks duration. Fever was said to be high grade, intermittent, associated with she and rigor, temporary relief by antipyretic. This is very important. It showed that Lassa fever can actually mimic other infections like malaria. In this instance, it is mimicking malaria. But it can also increase upper respiratory tract infection. It can mimic gastrointestinal infection. It could mimic infection in any part of the body. So Lassa fever is a great mimic. This patient also had headache, which was generalized, throbbing in nature. There was no neck pain, blurry vision, or photophobia. We need to say this because we've had the signs of patients with Lassa fever that also had meningitis. Okay, but this patient did not have. Patient vomited about 3 to 4 times per day. This episode contained recently injected meal, and it was about 50 to 100 ml. It was not bloody, does not contain bile, and the vomiting was present in presentation. Patient had associated epigastric and periumbilical pain, burning in nature, non-radiating, no relieving or aggravating factor. His appetite was poor. He had no abdominal distension or passage of loose tube. Patient had no contact with Lassa fever patient or participated in burial rites of persons who died from Lassa fever. We have high index of suspicion whenever we see any febrile case in our hospital, because this region is endemic for Lassa fever. We don't just assume it is malaria. You can see we are already taking history to detect, are we dealing with Lassa fever or something else? However, there was rats in the vicinity of this patient, and his food items were not stored in rodent-proof container. This can serve as a lesson to us all, okay, because we know the reservoir host for Lassa fever to be the multi-mammoth rat. We should protect our food from rats from getting access to our food. Initially presented to a referral center where Lassa PCR was requested. This is an investigation to detect Lassa fever. We said the gene of Lassa fever from the blood sample, and the result was positive. It was subsequently referred to Lassa Fever Hospital for expert care. He had no previous history of kidney disease, and his past medical history was not remarkable. We need to establish this background. When we examined this patient, he was a young man, conscious, was not febrile. Of course, we know it was coming from a febrile center, patient that might have been having paracetamol antipyretic. Maybe that was why the patient was not presenting fever at when we examined. Was not pale. Patient had no jaundice, was not cyanosed, though patient was mildly dehydrated. He had no significant peripheral lymph node enlargement, no distal clubbing, there was no pededema. The nervous system was essentially normal, there was no focal knowledge deficit or global knowledge deficit. The cardiac test showed that the BP was reported was 60 beats per minute, normal volume, regular synchronous, and the blood pressure was 124/85. I want us to note this because I'm going to bring out a complication of Lassa fever that we observed in some of our patients. The ulcer was first and second ulcer only. Chest was clinically clear. Breast was vesicular. The oxygen saturation was 98% on room air, which is that patient was not having respiratory embarrassment. But in the abdomen, it had epigastric tenderness. Other findings were essentially normal. We made the assessment of Lassa fever, and our plan was to we admitted that patient in Lassa fever main ward. We collected sample for full blood count, electrolyte urea and creatinine, liver function test, urinalysis. We commenced on IV 5% dextrose saline, 500 ml, which is we had 2 cc of vitamin B co. This is actually to present a complication that we refer to as wenic encephalopathy. This patient had not been eating for a while. The appetite had been poor, had been vomiting. It was at risk of having thiamine deficiency. And giving this patient dextrose can see the patient to acute thiamine deficiency causing wenic encephalopathy. We also started the patient on empirical broad spectrum antibiotic because from my experience, their immunity is usually depressed. They are at risk of having superimposed bacterial infection. So we want to control for this from the outset. We started on IV intravenous omeprazole 40 milligrams hourly because of the gastritis, which was evident by the epigastric tenderness. The patient was not fever, and then we are planned to commence on antipyretic if fever developed. That same day on admission, patient later started having temperature spikes, temperature between 38 to 39 degrees centigrade, also starting passing co-color urine and had melinal stool. Melinal stool means that patient was passing black, tarry, shiny stool. It is indicative of upper GI bleeding, meaning that this patient was already having internal bleeding because of Lassa fever. Fluid input is 3,000 over 1,400, during after 1,400. And don't get bored. I will be talking about fluid input and output day to day in this patient because it's very crucial. Like Dr. Moses said, we need to monitor it to really assess kidney damage. Investigation, the PCV fascia volume was 48.9%, platelet was 225,000. Patient had increased white blood cell count, which is indicative of infection. There was granulocyte predominant of 50.9. The electrolyte urea and creatinine at this point was normal. And I want us to know this fact because the fact that you are seeing a patient coming with a normal electrolyte urea and creatinine does not mean the patient does not have a kidney damage already ongoing. Ischemic acute kidney injury occurs in 3 phases. We have the initiation phase, we have the maintenance phase, we have the recovery phase. In the initiation phase, when the injury is evolving, the electrolyte urea and creatinine may actually be normal. So that's why we need to constantly monitor. Like we see this patient, the ARU was essentially normal at this time. Then, because of the temperature spike, we comment on antipyretic, that is drug to reduce the body temperature. Like the first presenter said, this fever in itself can cause damage the kidney. So we need to control for the fever. By the 3rd day on admission, patient was still having temperature spikes and vomiting. Fluid input and output was 4,100 over 2,200. Pack cell volume, which is the measure of the red blood cell in the patient, was 52.1%. The platelet was within normal limit. The white blood cell count appeared to be increasing. We call this leukocytosis. Okay, it has increased to 17,000 per cubic millimeter. And now there was a slight shift from granulocyte predominant to marginal lymphocyte predominant. The electrolyte urea and creatinine show marginal increase in serum creatinine of 0.1 milligram per dl. Okay, like I told you, this patient is probably at the initial phase of acute kidney injury, but we are monitoring. Because of the vomiting, we placed on IM metoclopramide 10 milligram 8 hourly to control the vomiting, and we continue that line of management. This patient has been commenced on ribavirin according to the ERA protocol. And the ERA protocol is that we give a loading dose of 100 milligram per kilogram body weight on day 1 up to a maximum of 7 grams. We give 2/3 of D start, we give the remaining 1/3 8 hours later. Then from day 2 to day 7, we give 25 milligram per kilogram body weight as a single dose. Then from day 8 to day 10, we give 12.5 milligram per kilogram body weight as single dose. So the patient was already on this with other management, ribavirin. Okay. Now, by day 5 on admission, patient was still having temperature spike and epigastric pain, but at this time, vomiting has subsided. The fluid input over urine output was 3,000 over 1,250 ml. The blood pressure was 120 over 88. You can see that systolic rising. PC was 55%. At this time, the platelet count was higher than normal. We call that thrombocytosis. And this is one of the changes we observe in patients with Lassa fever. They can either have low platelet count, normal platelet count, or high platelet count. But that does not mean they will still not have bleeding tendencies, because the hypertension of platelet by Lassa is not only quantitative, it can also be qualitative. At this time too, the white blood cell count appears to have further increased to 21,300 with granulocyte predominant. At this point, patient had azotemia, that is elevated nitrogenous waste in the blood. The urea was 60 milligram per day, creatinine was 3.7 milligram per day, and based on the definition that I gave earlier, this patient merits a diagnosis of acute kidney injury. So it is established here, it is objective here that this patient had acute kidney injury as a complication of Lassa fever. So the nephrology team was invited, made the assessment of Lassa fever complicated by acute kidney injury. The dose of ribavirin was halved because ribavirin itself can be toxic to the kidneys. So it were between the devil and the deep blue sea when we are managing patients with acute kidney injury due to Lassa fever. We need to use ribavirin to eliminate the virus. Ribavirin is that's what we use off-label to eradicate the virus. But we also need to control the dose of this ribavirin so that we don't precipitate further renal damage, because about 60% of ribavirin is secreted in the urine. And if in a situation of kidney failure, this ribavirin can accumulate to a toxic level that can further damage the kidney and affect other organs of the body. So we reduce the dose. We requested for repeat E and U, electrolyte urea and creatinine for the next day, and we also work this patient out for hemodialysis if there was upper review in serum creatinine, upper rise in serum creatinine. What we're doing here in essence, we started patient of conservative management, optimize lead, have the dose of ribavirin, then observe the impact that was going to have on the electrolyte profile during and creatinine of this patient. If the patient responded to conservative management, we may not need to do renal replacement therapy in this quick modality. But if the patient condition was worsening, may have to step higher by taking over the function of the kidney through the procedure called hemodialysis. So, by the 6th day, patient noted to be having facial puffiness, abdominal distension, leg swelling, and was still fever. This showed that the patient was having fluid retention. Despite the fluid input and urine output was 2,100 over 2,050. Investigation at this time showed PCV of 46%. The white blood cell count has further increased to 22,000 per millimeter, despite antibiotic and ribavirin, and the platelet count was also higher than normal, which is not unexpected. At this time, angioedema is objectively worsening. Creatinine had increased to 4.6 milligram per dl. Urea had increased to 77 milligram per dl. There was low level of sodium, and the bicarbonate level was low, which was showing metabolic acidosis. These are the renal complications that can come in patients that has Lassa fever, as already highlighted by the previous presenter. The abdominal ultrasound suggested acute renal parenchymal disease, then hepatomegaly chronic cause. Patient had 4 sessions of modalities on the 6-day admission, but we gave 2 hours. And the reason we do this, we don't want to crash the angioedema too drastically. We don't want to, angioedema by mean the nitrogenous waste that are accumulated in the body, we don't want to reduce it too aggressively. Because if we do, we stand the risk of having the patient develop a life-threatening complication that is referred to as dialysis disequilibrium syndrome. So we have to be gentle. We just remove small. So that's why we did on the 4-day 2 hours.
Dr. Asil, just I'm sorry to interrupt. We have just less than 10 minutes for your presentation. Thank you.
Okay, good. Yeah, by the 7th day on admission, we saw that the angioedema was still the angioedema was still worsening. Then the platelet count still showed that the platelet was high and leukocytosis was worsening. That's white blood cell count. Then the liver function, liver enzyme was elevated and the albumin level was low. The fluid input and output is as shown. Patient had second session of modality, which was 4-hour session. By the 9th day admission, patient had been fever-free for 48 hours. The fluid input and output was 2,100 over 1,100. Angioedema was still there. Okay, the urea was 86 milligram per dl and creatinine was 6.3 milligram per dl. The white blood cell count was 22,500. By day 11 admission, patient was clinically stable. The patient still has low hyponatremia. This patient has been having dialysis, and this patient has been on saline infusion. And the angioedema had worsened. Urea was 108 milligram per dl, creatinine was 8.7 milligram per dl. White blood cell count, though still high, appears to be on the downward trend. Liver enzyme also seems to be resolving, but the serum protein albumin was still low. At this time, we commenced on salt poor albumin. We also commenced on egg white so that to raise the serum albumin. And patient had 3rd and 4th session of modality on day 11 and day 13. On the 16th day admission, we see that the angioedema appears to be on the downward trend. Urea had dropped to 68 milligram per dl from 108, and creatinine had dropped to 4.3 milligram per dl from 8.7. But I want us to pay attention to the fluid input and urine output here. It was 2,900 over 3,700. This shows that these patients were diuretic. This is a good sign for us as nephrologists, because we know that the patient has entered the recovery phase of acute kidney injury. We call it diuretic phase. At this stage, we don't need to dialyze again. We just need to pay close attention to the electrolyte and the fluid therapy. So we monitor the electrolyte and creatinine and optimize the fluid therapy according to diuretic phase protocol, which I can expatiate on in the discussion. We control the line of management. By the 17th patient was having improved clinical state, but the blood pressure of 160 over 100. We noticed that patient had high blood pressure. That's why the patient did not present with high blood pressure. This is one of the complications that we see some of our patients, new onset hypertension. So we started the patient on low dose methyldopa, which we increased to 500 milligram BD. By day 18, patient was stable. The angioedema was recovering. The blood pressure was still high. We requested for post-treatment Lassa Fever. By day 21 admission, patient had been 15 days on IV ribavirin instead of 10 days. This shows that because of the AKI, patient had prolonged viral shedding and the admission was prolonged, which in itself is poor outcome. Lassa Fever was still positive. Clinically, patient had improved. He was making adequate urine. By the evening of that day, the serum creatinine had dropped to 1.4 milligram per dl from 8.7, which shows that we are winning. With continued management, place close attention to the fluid and electrolyte balance. By day 3, patient became Lassa negative, but was still diuresing. The blood pressure was normalizing. Patient was still at the recovery phase of AKI, and plan was to continue management. By the 24th day on admission, the urea had normalized, the creatinine was marginally elevated, patient still had elevated platelet count, but patient was clinically stable, diuresis and restored. Plan was to discharge patient to follow up at the nephrology clinic. 1 week at follow-up, the electrolytes, urea, and creatinine are normalized, which means that renal function has been restored. Patient was completely out of AKI. On subsequent follow-up, renal function was stable. In summary, he was a 27-year-old theology student who had Lassa fever complicated by AKI. He was treated with ribavirin, had both conservative management and renal replacement therapy for acute kidney injury. He was admission for 24 days, which was out of the ordinary. Okay, many patients would have been admission for less than 10 days. AKI resolved and he was discharged to follow up at the nephrology clinic. His electrolyte profile and creatinine had normalized at 1 week follow-up visit to the clinic, and patient renal function remained stable on subsequent follow-up visit. By way of discussion, AKI is a frequent complication of Lassa fever. It is established to be associated with poor outcome Lassa fever patients if not decisively addressed. Acute kidney injury Lassa fever is mostly due to intrinsic and perennial causes. Presentation of AKI in Lassa fever is not different from other causes. I have a paper on this that is on the process of publication. So AKI in Lassa fever presents the same way as AKI due to other causes. Management and take judicious history, physical examination, targeted investigation, and focused treatment. But we should note that it's highly infectious, so we should adopt our infection prevention and control through the use of our PPE, personal protective equipment. Most importantly, measures should be taken to prevent AKI in Lassa fever patients. In conclusion, our study on clinical and laboratory data of Nigerian Lassa fever patients provided strong evidence of increased renal dysfunction in Lassa fever. Acute kidney injury has significant associated with poor outcome, though these patients survived but had prolonged hospital stay. Prevention, early recognition, and treatment of AKI will significantly reduce mortality. These are my references. Thank you for listening. Over.
Thank you very much, for this detailed and informative case. So we are going to move into our Q&A and discussion segment. We already have some questions already asked in the chats. But if you want to ask your questions directly, don't hesitate to use the raise hand function. So I will start with the questions we have already. I think we have around 6 questions. The first question was by Muhammad Saleh asking, what is the role of albumin therapy in place of dialysis if capacity is limited? I don't know whether Dr. Rafiu, if you can take this question, please. What is the role of albumin therapy?
Thank you very much. Am I audible?
Yes, we are audible.
Okay, now albumin therapy does not replace hemodialysis, even in situation whereby the capacity is limited. So the appropriate thing to do is to refer the patient to where there is facility for hemodialysis. However, if you notice the case illustration, I place this patient on stop for albumin because the patient has hypoalbuminemia. Okay, low serum albumin is a bad prognostic factor in patients with kidney injury. So we need to correct that. That was why I placed. So it is an independent factor for mortality. So that's why we have to replace with albumin therapy. But otherwise, if the patient had normal serum albumin, I would not have had any cause to place this patient on albumin. So albumin does not replace hemodialysis in patients with AKI. Thank you. Over.
Okay, thank you very much, Dr. Rafiu. I don't know whether Dr. Tuko has something to add to the question. Dr. Moses, I think you are muted if you are speaking to us. Okay, so maybe we can switch to the direct questions. I can see two hands up. Iheka Ezime, can you go ahead with your questions?
Hello. Okay. Some people are raising their
Yeah.
hand.
Yes, I've prompted Iheka Ezime to proceed with his question, but I don't know whether he can hear us.
Oh, okay, yes. I
Otherwise,
wasn't able to. I can hear you
thank
now. I wasn't able to unmute earlier, but I've been able to do that now. So thank you for the presentation to Dr. Chuko and Rafi. So my question is regarding the case presentation. So the patient was seen at Edo Uromi Irua Axis, which is very well is reputable for managing Lassa Fever cases. So I'm sure that level of awareness amongst private and public health facilities there will be high. So that will make a provider to start thinking of Lassa Fever when they see a febrile patient. So that may be why they're able to think of requesting for Lassa PCR. I'm just thinking in other parts of Nigeria where we don't have such awareness, what's the availability of Lassa PCR to a provider that's probably in the north or in other parts of Nigeria where Erua is not close by? Do we have access to such testing routinely, or what's the NCDC approach to making diagnostics available to providers that are outside the popular areas where we know that Lassa fever prevalence is quite high and the people are more aware of it? That's my question. Thank you. Over.
Okay, Dr. Phil, do you want to take this as well?
Okay, thank
Yeah.
you very much. Okay, so let me take it. I must admit that the capacity for Lassa PCR is not that widespread. We are privileged to have at Ira Specialty Hospital and in some other centers. So because of this limited capacity, that's why from all over, people still send sample, for instance, to ISTH, okay? Maybe the NCDC people are here. I can also see my director, his hand is up. He may also want to add one or two notes to that. But I know that there are reference labs across the country, but it's not every hospital that has the facility to make the diagnosis of Lassa fever using PCR. That's why we get referral, we get blood sample from all over the country at Rural Specialist Hospital. I also believe that NCDC probably also has that facility for diagnostic, and sample can also be sent to NCDC reference laboratory. Okay, so I think I will stop at that for other people to comment. Thank you.
Okay, let's quickly go to Dr. Tuko. I think he has some comments to add.
Yeah, thank you. Thank you very much. I was trying to unmute earlier. Sorry about that. And it was not allowing me to. So quickly, like he said, I am an example of a practitioner in the north. I'm in Kebbi State, and it's actually a challenge, like he said. We've had some cases, about 13 cases in our series, and we have to rely on the NCDC reference lab in Gudu to have our PCR. And the turnaround time is somewhere about 5 days to 1 week. So you can imagine the challenge of it. So it's actually a problem. And I know there are supposed to be molecular labs, even in my own facility like that, molecular labs around, but for the biosafety level for Lassa, most of them have not been able to run. We have to use NCDC. That's the closest. I know Bauchi too is able to run something like that. I'm not sure of JOS. But quickly to add, for the other one that you said, it's important to mention that for Sally and Dr. Rafi, our senior colleague, has answered it. They are mutually exclusive. Albumin is albumin. Dialysis is the mainstay of treatment for those who have uremia and they require. So they are two different things altogether. But like he said, in the cases of management, you find reasons so nephrologists could bring it on board like he did in the case he managed. But albumin, if you look at the mechanism of AKI, it is not about loss of albumin. There's nowhere it is a mechanism. But when you have glomerular basement membrane issues in nephrotic syndrome, which is a different disease altogether, you could have loss of serum albumin as a manifestation of a disease, and protein replacement, sulfur albumin, becomes a mainstay of treatment. So there are two different things altogether. It doesn't replace. Thank you.
Okay, thank you very much for that input. I saw Dr. Joseph's hand, but it's disappeared now. I think Prof is also wants to speak. Dr. Mursala Abdullahi.
Hello. Good morning, everybody on the call. Good morning, the Georgetown team, the organizers of this event, Nigeria Center for Disease Control, the presenters, Dr. Tuko Moses, Dr. Mojid Rafiu, for the very excellent presentation. And I believe that they really touched all the areas that met the objective of this discussion. Yes, like we have always said in the past presentation, managing Lassa virus disease goes beyond giving just ribavirin. We can see from this presentation that the most important aspect of management is supportive care and management of complication. And when these are properly done, patients do well and do very well, other than just depending on the ribavirin alone. So I really appreciate their input in today's discussion. And I must say that over time, in the past 4 to 5 years, there has been an expansion in diagnostic scope. More centers are now being able to make diagnosis of Lassa virus disease. I can tell you, in all the geopolitical zones of Nigeria, NCDC has actually provided a laboratory which serves as a reference, as a referral lab for making diagnosis of Lassa virus disease. In the West, you have one, and there are some centers in Lagos, like 2 centers that I know where Lassa PCR can still be done. Then in the East, you could have Abakaliki, and then in the North, Bauchi, yes, very well. Abuja, you have the National Reference Center Laboratory. Bauchi is growing every day. It's becoming very big, and is now able to do a couple of things, not just the Lassa PCR, but a couple of supportive investigations for emerging viral pathogen. Yes, the diagnosis scope has long expanded, but the delay is usually in transport of some of these samples to this reference laboratory. And I believe at some point, the Nigeria Center for Disease Control, we're putting together some training system, because the challenges people face is they have a suspect case, and probably they know that the reference laboratory is some distance from the center where those samples are to be sent. So they are challenged and not too sure of how to move some of those samples to centers where such diagnosis can be made. And also, the turnaround time for centers also varies. So these are some of the things probably NCDC can strengthen, because I believe that Lassa virus disease being common in some area is also due to the fact that the diagnostic facilities are available in such areas. I still don't believe that Edo or Bauchi and Abakaliki has the largest burden of Lassa virus disease in Nigeria. But you see this area, they have active diagnostic centers where diagnoses are being made. So diagnoses are made there, you see this coming. And this is possibly what we are seeing from the currently enabled 1.5 studies that they are doing, where we are having very early cases of Lassa virus disease being diagnosed, because people you see very symptomatic with mild symptoms you think have malaria, and you are testing them and they are having Lassa virus disease. So you have this very common in many other areas. That's what I'm beginning to think. So I feel that NCDC should begin to strengthen the transport system so that those who have these suspect cases can have the channels, easy channels, to easily get sample into some of these labs and get tested. And then with more community sensitization, we can do more in primary prevention of Lassa virus disease, while we still await vaccine, which still remains the veritable strategy to end or curb the menace of this condition. So thank you very much. Thank you, Dr. Rafiu, once again, and your team who prepared this slide. And I also appreciate Dr. Tuko for the beautiful presentation. Thank you very much, Georgetown. Thank you.
Thank you very much, Dr. Joseph, for that insightful contribution. I'd like to call on Dr. Mursala to also maybe question or comments. You can unmute and speak.
Yeah. Hello, thank you very much for your presentation. Am I audible?
Yes, I can hear you.
Okay. My first question is regarding infection prevention and control. For example, like in Aminu Teaching Hospital, we have a comprehensive dialysis center where we dedicated the machines for PL-HIV or hepatitis B surface antigen clients. So is there a need to do the same thing also for Lassa Fever client, considering the fact that the prevalence and the number of cases we are getting are not that much and much frequent? Is it possible maybe to avoid the usage of for example, dialyzer and treatments? For example, if you dialyze a client and maybe you reuse it again, because of the fact that we had a client that traveled from Bauchi. So being at having to raise maybe high index of suspicion whenever you see a client come from Bauchi with a case of contact. It's a contact case of Lassa fever, but she happened to come in contact with a lot of clinicians in Aminu Teaching Hospital, from GOPD to ONG, where she was attended to. It led to operation table, where the client arrested, the anesthesiologist who gave her CPR happens to develop Lassa at the end. So it gave us a painful experience at the end. So that person most likely developed multi-organ dysfunction, most likely AKI, and died. So we lost him. Up to now, it's a case to remember. So how can we go about addressing infection prevention and control around maybe dialysis unit, if possible, if we had the case? And that still needs to be shared to the virologists in the country so that at least they can know. We never can tell when the case will come up for Lassa. That's it. Thank you. And maybe possibilities of having center of excellence in Nigeria, maybe in the north, otherwise in the state possible. What NCDC is doing. Thank you.
Okay, thank you very much, Dr. Musala. I think some of your questions have also been answered in the chat box. Dr. Bala Borate from the NCDC made some comments regarding some of the questions you asked. So we are running out of time, and we have not answered most of our questions. So I'd like to quickly go on to the second question that was on the chat. Regarding Adam Omar asked, is it necessary to adjust the dosing of ribavirin in case of Lassa fever with AKI? Dr. Tuko Moses, would you like to take this? You are muted.
Dr. Tuko, you are muted.
Okay, thank you. Yes, I was not being muted earlier. Thank you. So yes, like we saw in the case presentation of Dr. Rafiu earlier, ribavirin itself is nephrotoxic to an extent that has some form of interstitial nephritis, but generally it's safe. So when you already have evidence of kidney injury and or some form of uremia, it's very important to regulate or down-regulate the dose of ribavirin. So you will see in the index case that was presented, the team also did that practically by halving the dose of ribavirin. Don't forget, ribavirin has its other benefits, but that nephrotoxicity is one of the sides. So even in the use of ribavirin, even for patients without, it's always good to have a baseline and monitor the degree of change of serum creatinine as you give ribavirin. Is one of the mainstay of management in the use of ribavirin. I hope that has been able to answer that. Then just to quickly add for the IPC component, one of the things of note, I'm sure Dr. Rafiu has that experience practically being in the dialysis center that is active. Nephrology units have had a good report or outcome for IPC and dialysis because renal dialysis comes with good IPC measures in the first instance. So you discover that we've not had cases of infections circulating in renal dialysis unit because there's that IPC practice. But it's important to add that because a blood-borne infection, just like you said, for hepatitis B, hepatitis C, RVS, Lassa is even more infectious, most infectious. Maybe hepatitis B will come close to you. So it needs to have its dedicated system, a dedicated machine. The tubing should be completely different. So that's why there's a need to establish those centers of excellence and even movement around patients. Don't forget, in the practice of dialysis on its own, one machine can serve everybody. It's about IPC. But because we have noted that infectious rate among, even for hepatitis B, hepatitis, so that's why we have dedicated machines for all, including a disease like HIV that is not even that infectious. So it's a practice to have dedicated machines. It's a practice to train the team better on IPC so that single-use equipment, there's no place for reuse. There's no reuse. Just to quickly answer, there's one equipment, one set of dialysis consumables, and you discard after then, like all other infectious materials are discarded. Thank you.
Okay, thank you very much, Dr. Moses. I don't know, Dr. Ojawe, can you just give your comments or questions in the next few minutes? We are really running out of time.
Okay,
And,
thank you so much. I've been trying to see how I could speak since. First, I'll say thank you to the presenters, who I think I know very well, and they did very well with their presentation. And thank you, NCDC, and also Georgetown. So mine is comment, looking at the future, and my director too also spoke very well concerning the illustration of the IPC and other aspect of Lassa Fever. I just want to ask my question and also make a comment. My comment is looking at futuristic approach of Lassa Fever. PCR is going to be very difficult for so many centers for them to start doing. And also looking at the cost of PCRO, maybe a time will come where individuals will start doing paying for PCRO. So my thought is, can we not start having RODT for patients for different centers, starting from the local government, health center, and also the teaching hospital? That's what we have for malaria. That can also help in terms of morbidity and mortality of people being suspected of having Lassa fever. We saw this in COVID, why it was very difficult for many centers to start doing PCR. We started doing RODT. It may not be highly sensitive and specific, but at least you can get up to 80 to 5% from doing that. So I think that may be our goal or futuristic approach for that. That's one for my comment. Let's look at as an RODT kit for it. Then secondly, the issue of continuous replacement renal therapy is very important. So I know the first speaker was talking, but I didn't see that in his slide. We have to look at that because there are some centers where you dialyze the patient today, probably because there's hypotension, and you are scared of dysequilibrium syndrome. You don't want to dialyze that patient. But when we have this continuous renal replacement therapy, even when there's hypotension, the machine should be able to look at that. So those are just my question and my comments. Thank you.
Okay, thank you very much. Dr. Rafi, would you like to take these questions?
Thank you, Dr. Idiawe Usas. He's one of our infectious disease physicians here in Rural Specialty Teaching Hospital. And the point he raised is actually very germane, okay, looking at the futuristic approach. RDT, the rapid diagnostic test kit, okay, should also have a space, for early diagnosis. Okay, but we know the drawback that it cannot be as sensitive or specific as PCR, but it should still have a place. But as at now, we don't have such kits. Okay, we are hoping that in the nearest future, maybe we have such kits. So I think that will help centers that don't have the capacity for PCR, okay, for early diagnosis. Once the RT is done, if it's positive, patient can be referred instead of waiting for the sample to get to the reference lab, then get back before now referring the patient. But like I said, the drawback could be that could be false negativity, that could be false positivity, but those ones can still be controlled for. So thank you, Dr. Dawe, for your comment. As regards cultural respiration therapy, beautiful. Yeah, it's not every center that have the capacity for continuous respiration therapy, but in Ira Hospital, we have the capacity for continuous respiration therapy. The issue is the cost, the expenses. In patients that are not cardiovascularly stable to withstand the conventional intermittent modality, continuous respiration therapy come in handy for them. Okay, so but either continuous respiration therapy or intermittent dialysis, both of them have what you call comparable survival rates and good outcome for patients with AKI. Thank you very much.
Thank you very much, Dr. Rafi. And unfortunately, we are completely out of time. And apologies for this. We are not able to take all the questions, but we will be able to. We will try as much as we can to answer the questions offline and send them subsequently with the slides. But before we go, the last comment I would like us to take is from the NCDC. I know a lot of things have been mentioned around enhancing transportation, enhancing laboratory networks, and so on. I don't know whether Dr. Boratai or any other person from NCDC could just give few comments in a minute or less about this. Okay, so I guess we'll be able to address some of these issues that have been raised. But to formally conclude, I would like to call on Dr. Winfred to finally bring the webinar to a close. Please don't forget to fill the webinar evaluation form. We have greatly improved it. It's much easier to fill now because of the feedback we got from the last webinar. So kindly fill the evaluation form, and Dr. Winfred, please proceed.
Good morning, everyone. Thank you, Dr. Fina, for this. Just give me a few minutes of your time. I know we've gone past the hour, or we've gone past the time slated for this webinar, but just to appreciate the speakers for today in the person of Dr. Moses Tuko and Dr. Lighton Rafiu, two seasoned nephrologists who have been managing Lassa Fever cases and complications, renal complications of Lassa Fever for taking out their time to, run us through how this works, how the complications come about, how to identify the cases, and what to do, irrespective of the setting in which we are. Thank you very much. And of course, to our participants for staying this long. It's your participation that keeps the webinar going. Thank you for your time. But just to maybe go over some key takeaways for us, especially in this period where we are in the Lassa Fever season, and there is an ongoing outbreak in the country. It's important, like Dr. Rafiu and Dr. Moses said, that we should be looking out for urine, the volume of urine, ask those questions. We know today that AKI can present asymptomatic, and it's always good to have that high index of suspicion, which is something that we have been talking about over the years, as to having a high index of suspicion for Lassa. And when you see a patient with Lassa, always think that this patient may have a renal problem, because as we know that people would move from one facility to the other before they get to the place where the solution will be found. And a lot of interventions may have happened, some of which they may be able to remember, some of which they may not be able to remember when they're engaging, or when you're seeing them for the first time. So I think it's very, very important. And like Dr. Rafi has said, we saw the statistics, 65% mortality from AKI. In ISTH alone this year, 28% of their patients have been managed for AKI, which is about 1 in 4. So that means for every 4 patients who were Lassa positive, 1 of them came down with renal problems. So it tells you that it is really a big challenge. And that is the essence of having this webinar, for us to discuss and to learn more on how to address this challenge. So thank you very much to the speakers for sharing their wealth of experience and their wealth of knowledge. So just to state that we will be having the next webinar. It will be holding next month, the month of March, on 27th of March to be precise. The webinars happen every last Thursday of the month. So it will be 27th of March. We will send out, of course, the notification and the reminders and the emails for you to register. And please do well to also share with your friends and your colleagues, co-workers, so that they can all be part of it. Also, the evaluation, like Dr. Kuna said, please help to fill the evaluation form. It is when we hear from you that we are able to be better and able to even identify maybe some key challenges that you may want to be addressed in the webinar series. So please do well to complete the weekly evaluation, and let us hear from you on how well this webinar has gone and what you would like to see. So on that note, I want to thank everyone, and see you next month. I'll hand over to Dr. Kuna, who is moderating the session. Thank you, and over.
Okay, thank you very much, Dr. Onifred. This brings us to the end of this webinar. Please remember to fill the form, and we have taken note of all the questions, and we'll be able to, we'll try as much as we can to send them across with the slides and the recording. Thank you very much, and bye for now.